All, this is Dr. Mobeen Sayed from Drbeen.com. Welcome to another show. Today we are going to talk about the case of reinfection that is seen in Nevada, USA. So let us start our discussion. I am going to share my screen. So this is Drbeen.com. And then if we go here, this is the study that has been published in the Lancet, where they're talking about the case, and I would describe that in a second. Generally, what they're saying is that there is a young man, 25 years old, Nevada resident, who had infection in April, and then he recovered, and then he developed the symptoms, more severe symptoms, with SARS-CoV-2 and tested positive again in May and June timeframe. So then there are a bunch of possibilities that we are discussing, that what could cause the reinfection. So I want to start this context right in the beginning, that in the US, out of all the cases, I believe now about 10 million, this is one case of reinfection, confirmed reinfection. And then in the world, there are so far 5 cases of confirmed reinfection, although the overall cases are more than, I believe, 30 million. So keep that in mind. And now let's look at what is the observation. There is another link here, which is about further discussion of what reinfection means. And we'll talk about that too. And finally, we'll talk about Johnson & Johnson and Eli Lilly. They have paused their trials. So I believe Johnson & Johnson has paused their trial for vaccine, and Eli Lilly has paused their trial for monoclonal antibodies because of some severe symptoms or unexplained symptoms in the groups that are receiving or that are in placebo of the drug. So with this, let's start. So here, it is actually a very fascinating study, and we're looking into the mechanism as well. So here is Nevada. It's actually next door to California. I live in California, and we go to Nevada sometimes for boating. There is a lake there. So here is what happened. 25th of March, this young man had SARS-CoV-2 symptoms. They were milder. Then he stayed sick with them, and on 18th of April, he was tested positive. Then he recovered on 27th of April, stayed fine through May, and then at the end of May, 31st May, and in June, he had a couple of events where he became sick again. Then on 5th June, they tested him again for SARS-CoV-2, and he was positive. The symptoms that he got the next time around were more severe. So if we look at the timeline, here is what was happening. On 25th March, first set of symptoms. The first set of symptoms were he had nausea, headache, nausea, sore throat, cough, and diarrhea. That was the first time, rather mild for him at that time. RT-PCR was positive on April 18th. Then resolution, he became okay on April 27th. So March 25th he started, and April 27th he recovered. Then he tested negative on May 9th. He tested negative again on May 26th. So that is quite a distance between the two tests, which actually makes it better. So he was negative at that time. Then on May 28th, he started becoming sick again. He went to an emergency room, or he went to find the medical care. This time what happened was he had dizziness, headache, nausea, fever, and cough and diarrhea. So dizziness was added, nausea and fever had been added. Then on, I think, a couple of days later, he had to go back to the hospital because now he had developed the shortness of breath as well and hypoxia as well. So the symptoms became more severe, and the chest X-ray showed the viral pneumonia signs as well, which is the signs of interstitial pneumonia. I have talked about that in the past, or the signs of walking pneumonia. So this is mostly the interstitium of the lungs that becomes infected. So he had the signs on chest X-ray as well. Now, this patient had no obvious cell count issues. For example, if he started thinking that maybe his immune cells are not correctly being produced, or the cells are destroyed more. So no obvious cell count issues. He has no comorbidities, and his immune disorders, there are no immune disorders. There is no HIV. There are no immunosuppressive drugs he's taking. So there is nothing that says that this patient's immune system should not respond correctly, and that is the reason that he got reinfected. Now, here is what they found, and this is an important thing to observe. The first time when he became ill with SARS-CoV-2, the viral genome that they observed or that they extracted from him was different, and significantly different from the genome that they extracted from him or they took from him the next time around. So between April to June or end of May, the genome had, the two genomes were significantly different. And at that time in Nevada, there were 171 various mutations of the SARS-CoV-2 that had been observed. An important thing to note is that from this rather, let's say the first version, which they call specimen A, to specimen B, the changes were so many that these were not possible to occur within one person. So for example, if that person got ill with it, and now within a matter of 48 days, the virus had to mutate so fast within the same person and at a rate that was very high, which is not seen for the SARS-CoV-2, to turn into the other genome, which means that he acquired the second genome from outside as well. It was not possible for the virus to hide within him and then change enough to become the specimen 2 or specimen B. The other thing that is important is that the specimen B occurred, or his second symptoms occurred, when one of his parents became sick. So they're still trying to figure out that did the second specimen transmit to him from the parent, and they're not yet sure, so that data is not available. And I want to show you one more thing here. In this study, there was a beautiful graph here about the virus genome. So if you look at this one, this is the genome or various genomes that are present. Let's see if I can. So these are all various versions present. And if you see, the yellow one is the most common version. And this yellow version or version of the genome is called CLAD20C. Both genomes here, one is marked here, I don't know if it is clear to see or not, and the other one is here. Both genomes belong to the same strain or same bigger set of genetic mutation, and that is called CLAD20C. There were other genomes as well in Nevada at that time, but their frequency was less. Okay, so back here, continuing on. Now, if we compare this case of confirmed reinfection, there have been 4 more cases that have been reported of confirmed reinfection. One is in Ecuador, and the reinfection was more severe. This case in the US, in Nevada, which we're talking about, was also more severe. Then there were cases in Belgium, one case in Belgium, one in Netherlands, and one in Hong Kong. All of them had no significant difference in symptomatology compared to the original infection. So these are the 2 cases where the second infection was more severe. In the 3 cases, there was no difference, or it was same, or even in one case, there was asymptomatic second infection. Now, what are the possibilities? Why did this happen? So couple of things, why more severe symptoms the next time around? And then we'll talk about what is the possibility or what could be the cause of reinfection. So the first question is, why more severe symptoms? So first of all, it is possible that the viral load was high the second time around. So the second time around, when the patient received the virus, they received a higher load. Now, please realize this. We are talking from a immune system's response point of view. We are talking about two separate viruses. These are both SARS-CoV-2. These are two separate genomic structures. These are two separate strains of them. So yes, they are the same thing, but from an immune point of view, they were different. And what it seems is that the second time around, the person got exposed to the specimen B with a very high viral load, and that is what caused more severe symptoms, possibly. That is one possibility. Second possibility, that the second version, the specimen B, was more virulent. And we have done this discussion before as well, that it is possible for the virus to become more virulent, but in that case, for the virus to spread more also becomes a problem, because the virus would just continue to kill the patients. Here, the more virulence simply means little more virulent than before, that the symptoms are more severe, but still not sufficient to kill the person. So this kind of virulence or this mutation would still survive and continue to spread. Or it is also possible that the virus had genetic mutation, and maybe for this person it was more virulent. What does that mean? That this person's immune system's behavior towards this new gene, the new strain that he received, was more pronounced. So maybe there was some protein, maybe there was some mutation, there was something on this second specimen of the virus that made his immune system more mad. So maybe the strain was not virulent, but for his immune system, it was an immune system overreacted. So either the strain was virulent or it was virulent for this person only. So that is another possibility. Then another possibility is the antibody dependent enhancement. And this is the kind of mechanism that we've been talking about for vaccines as well. So what happens is that, let's say this person receives the virus the first time around. When he receives the virus, the innate arm responds, and then the adaptive arm responds, and then the antibodies are formed by the plasma cells or B cells. Those antibodies are now present in the body, plus the memory B cells are present. When the second infection occurred, imagine that the memory B cells now became active. They recognized the second specimen as well as SARS-CoV-2, reacted to it, created a ton of antibodies. Those antibodies, if you see here, they bound with the virus. And now, ideally, this binding of the antibody to the virus should cause neutralization of the virus. However, there is a concept of antibody-dependent enhancement, in which what happens is that the virus and the antibody, these two things bound together, then bind to the immune system cells, especially those cells that can do phagocytosis. For example, macrophages, for example, dendritic cells, for example, B cells, and so on. So when they bind there, they bind usually there by Fc receptor. So there are Fc receptors on the macrophages and dendritic cells, and those receptors have the site to bind with the antibody. So when this complex binds there, it is internalized or it is phagocytosed. This is almost like the virus found a new way to enter into the cell. Virus normally would use the ACE2 enzyme to enter in the cell, but when it is combined with, it is complexed with the antibody, now antibody has a way to get into the cell as well. And that virus, when goes into the cell, ideally the cell is supposed to kill it, but maybe in some cases it does not. And now the virus has entered the cell and has infected it and is going to destroy it. This is called antibody-dependent enhancement. And the more antibodies that are present, either because of the first infection or because of vaccination or some other dose of antibody given, if there are more antibodies present, there are a greater chance of antibody-dependent enhancement. Remember, it doesn't happen in everyone, but there is a chance to happen for this to occur. So maybe the next time around, when the reinfection occurred, then the antibodies were present as well, and they also helped the virus to infect more cells, and that is why the severity was more. Good. So 3 basic possibilities of why the severity was more. I actually think that the authors missed another possibility, and that is that it is possible that immune system overwhelmingly responded to some antigen on the specimen B where there was a mutation. And so the first time around, the immune system did not get dysregulated because there was some part of the virus that was innocent. In the second specimen, that was more virulent, and now the immune system responded overwhelmingly and became dysregulated, and now he had the severe symptoms. So there is a question by Arun. I could not understand FC ACE2. So let me just very quickly elaborate on this question. It is a good question. I had discussed that in the past, so let me explain it. So imagine this is a cell. This is a macrophage. And here is an antibody. Correct? An antibody has some virus or pathogen or some antigen bound to it. When an antibody and antigen are complexed together, there is a conformational change on the constant region. This is called the constant region of the antibody, correct? So this constant region has a change in it, which allows this to bind on the receptor present on immune cells. These receptors are called FC, or fraction constant part receptors. So now this part of the antibody can actually bind here and become connected. Once that happens, then the cell, the immune cell, let's say macrophage, is going to pick up this whole complex and internalize it into a vesicle. It is going to bring this whole thing in. So now imagine that this FC receptor is very similar to the ACE receptor on our cells. So let's say this is the ACE2 enzyme. And we know that virus can bind to this ACE2 enzyme through the spike protein, and that also allows the virus to become internalized. Correct? So now this mechanism is also helping the virus be internalized, and this mechanism is also helping the virus to be internalized. If this person did not have all those antibodies, then the only way for the virus to enter into the cell is going to be through the ACE2. However, now it is entering the cells through ACE2, plus now it has also gotten a new route to get into the cell, and that is by binding with the antibodies. So that is an additional route to enter a cell and infect it. This is called antibody-dependent enhancement of the infection. I hope that is clear, Arun. So going back here, so these are the 3 possibilities for severity. Let's continue our discussion. Then there is also a possibility that the virus became within the same person. It never went away. It persisted in the person, became more virulent, and then became reactive and caused the infection. What does that mean? So let's look at it together. What that means is that this was the first specimen of the virus, first generation of the virus in this person. And that generation caused milder symptoms. Then the virus went to a sleep. It slept. It hid somewhere. Maybe it went into some immune privileged sites. Maybe it just became dormant in some cells. It is not proven. This theory that I'm presenting has never been seen for SARS-CoV-2. So it may not be the right theory, but it is a possibility. So the previous virus, original virus was there, then it became dormant, then it became active again. But within the 48 days, when it became active again, it was causing more severe response, and we saw that the specimen was changed, the genome was changed. That has been a fact. So that means from here, from here till here, within 48 days, this virus has to do a lots of mutations. And during that time, it had to also become dormant, so that there was about a month of the time of no symptoms. This is really difficult for the virus to do, because this virus has about 24 something mutations per year. And if it had to do this kind of a mutational change within 48 days, it had to do, let's say, 70 mutations per year. So the rate of change had to be a lot for this kind of a behavior to occur. So maybe that occurred, but that from a genetic point of view, from a statistical point of view, is impossible for it to do it. So this is another possibility, although rare. Then, for the same thing to occur, for the virus to stay in the person, then resurface or become active after 30 days, and for 30 days stay quiet, there is another possibility, and that is this. The possibility is that the first time when the RT-PCR was done, that person actually had both specimens of the virus in him. And now think about it, this is all far-fetched, but hear me out. Both specimens, both strains were present even in April. Good. And the specimen, the test kit, only picked up or detected specimen A and missed this specimen B. And that may be because of the viral load, that the viral load for B was less and the viral load for A was more. So A was detected, B was not detected while it was present. Okay. Then what happened? Disease occurred. Then the person became okay. And then when the second time he became sick and the test was done again, now the A version had been killed by the immune system, while the B version that was sitting there in lesser copies had a chance to continue to evolve and continue to replicate or divide and increase in number, and now became detectable. So again, this is going to be a really remote possibility. This is going to be a difficult thing for us to kind of figure out how this can happen, but maybe this was the reason. So we have switched from why the intensity towards why the reinfection, right? So the first three things here that we discussed were why the intensity, high viral load, or the more virulent, less virulent specimen, or antibody-dependent enhancement. So these were why the reinfection. And now we're talking about why, sorry, that was why the intensity. The 4-1 is why the reinfection and why the more intensity. And now let's think about this one as well. Why reinfection? Maybe the first time around when the virus arrived in this person, the B cells, the plasma cells did not respond correctly, and they did not produce enough antibodies that the next time when the new specimen came in, when the new strain arrived, there were not enough antibodies to protect the body rapidly. So that may be the case as well. And in here is one more thing, and I talked about it yesterday with the water, fighting COVID-19 with water, and I talked about immunoglobulin A present in the moist surfaces of our mucosa, where immunoglobulin A are sitting there, and the virus, when it arrives, they are going to try to capture it and throw it out. So if the antibodies were less produced, or they were produced in less quantity, then the IgA, immunoglobulin A, or antibody A present in the mucosa will be less in quantity as well. That would expose the patient to become reinfected because the protection in the wet surfaces is going to be less. So maybe that was the problem, that the patient actually did respond, but the patient's immunoglobulins were less, so he was exposed the next time around to a new specimen. So now some of my conjectures. So the conjectures and the theories I presented earlier are by various scientists that I read about or read from. This is now some inputs from me as well, and maybe I'm wrong here. And let's do this together. We are all cool beans. We have been talking about immune system for some time. So think about it with me. Virus arrived again. The first protection is in the mucosa. Immunoglobulins, if they are less over there, then the patient has a chance to catch the virus again. So that is one possibility. That means B cells are not responding correctly. Let's say now the virus has crossed that barrier and infected the cells. Now that infection could be because of antibody enhancement, or it could be directly infecting the ACE2, binding with the ACE2 enzyme and entering the cell. Now, innate arm, so this part, innate arm of the immune system is supposed to have trained immunity, which means memory of the virus. And it is supposed to react better this time, and the NK cells need to do better as well. Maybe these cells did not do well. Maybe there was not enough memory in those cells, and so they did not respond well, and the virus had a chance to spread again. So that is one possibility. Another possibility is viral escape. What that means is that the first time around when the virus arrived in this person's body, the spike protein had a specific structure that allowed it to bind to ACE2. And the next time around, when it arrived from somebody else, this is a fact that it came from someone else. It did not evolve in the same person. It didn't have enough time to evolve in him. But next time when it came from someone else, maybe in that line, the spike protein had become mutated enough that it could evade existing antibodies, and now we needed new antibodies. So the virus escaped the previous mechanisms and infected again, which would mean that this patient would have to create the antibodies again against this new structure and then kill it, which this person did. He did have severe symptoms, but he was still able to overcome the virus. So that means the immune system did respond. So that is the virus side change. Then it is possible that the memory cells on the T helper 2 pathway, which is the antibody production pathway, maybe the memory cells were not produced correctly, or not in the right amount, or not with the right function. And so now when the virus appeared again, the memory cells were present, but they did not become active fast enough, or they did not produce enough antibodies, or maybe there were not enough memory B cells. Look, at the end of the day, the patient was reinfected. So there is some problem on the immune system to not be able to respond. So maybe the memory B cells were not present correctly or functioning correctly. Same thing for the cytotoxic T cells and the memory T cells. Maybe these guys did not have the correct memory. And so when the virus appeared again, in a normal other person, their T cells would respond quickly from their memory, and within an hour or two, and within 24 hours, they would react and kill the virus. And so the person would not even know that I got reinfected. We can be reinfected all the time. So if I got the infection today and I recovered, and then I go out, I can receive the virus again. There is not a shield that would say no more virus. The virus can still be able to arrive in our body. It's just that our immune system is going to respond to it so quickly and so rapidly and so unnoticeably to us that we would not even know that it arrived and we have taken care of it. So maybe the next time the T cells and the cytotoxic T cells did not respond fast enough. And that is also a problem with the memory cells. Of course, his immune system was good enough to be able to take care of the infection 2 times. So it is not that the immune system was not functioning. Maybe the memory system was not functioning. So that is another possibility. So reduced cell function, reduced memory cell production, viral escape, reduced innate arm function could all be the reasons that this virus was able to catch or infect the person and cause disease again. And I want to technically correct this, although in general terms we say reinfection, but the technical term reinfection can occur all the time. Reinfection simply means receiving the virus. Disease means when the virus causes enough replication and damage that the symptoms of some problem occur, then it is disease. Reinfection can occur to all of us all the time, even if we are immune, because nobody is going to stop a respiratory virus from entering our mouth from another person's mouth or nose air. But it is the disease, would that happen or not? So, okay, so these are my conjectures. Now, what are the implications? What is the outcome of this? So again, please keep this in context that 5 cases out of 34, 36 million cases, 1 case in the US out of 9, 10 million cases. So the possibility is really small, but still there are possibility and implications that we need to look at. What are those implications? Number 1, what about the vaccines? If a person, imagine that the first time around when the infection occurred in this gentleman, that was a vaccine. So the next time when the virus arrived, it caused the reinfection. So can the vaccines be effective? So my stance still is that yes. Why? Because this is a rare case. But will we have to end up like a flu vaccine for SARS-CoV-2, where the SARS-CoV-2 is continuing to drift away from its original structure, and our immune system cannot keep catching it? And so every time we have to figure out what are the strains of the SARS-CoV-2 in circulation this year, and then create most probable vaccines that can catch that and then vaccinate people every year. I think that that would be a rare thing to do, or rare possibility, but that is a possibility. So that has an implication for vaccines. Are there asymptomatic reinfections happening now? Is it possible, just like a gentleman who became reinfected and had symptoms, is it possible that other people are becoming reinfected and do not have symptoms? So I would say, once again, I think you're going to say that I continue to beat this dead horse, that reinfection is going to happen all the time. That simply means virus arriving in our body. Disease occurring again and again may be occurring, and would that be occurring with symptoms or without symptoms? So maybe there is a larger group of people who have recovered and now are becoming sick again, but they don't have symptoms. Maybe. And if that is happening, then what is their number? We do not know. And from a practical point of view, if they're asymptomatic, if nothing is happening to them, then who cares if the virus had arrived and got beaten up by the immune system and maybe caused them a little bit of a disease, not even symptoms, but spread a little bit and then went away. So what? Then this is a more important one, that people who are reinfecting, are they transmitting? And this, if you read it in this context, that are there people who are asymptomatically becoming infected? So of course they are not getting any problem with it, but then are they transmitting it or not? So that is yet not known, because we do not have sufficient number of reinfection cases to be able to go back and study them to see if they became the patient zero for others. Is this really a reinfection? Was this the virus just sitting in there for a long time? Or were the 2 strains present all along? Was this really a reinfection? Were the tests good enough? The test that said, yes, the patient is positive, yes, the patient is negative, and the patient is negative, were they good enough? Was there an error there? Has the virus found a way to hide in our immune privileged sites? So in our body, there are some sites there where immune system cells are not allowed to go. For example, testicular tissue has sperms in it. For our immune system, sperms are supposed to be, they're haploid. So our immune system takes them as foreign cells. So if immune system cells can get to sperms, they're going to kill them. So they're not allowed to go into the testicular tissue for this reason. So that is an immune privileged site. There are many immune privileged sites in our body where immune system is not allowed to come in. Can this virus go there and just hide there and just sit there and evolve there and then come out at a later time? Again, a rare possibility, but maybe. We do not know the answer to say deterministically, factually, that this is wrong. And then herd immunity by no lockdown. So let's say now I hear this from a lot of people, that we should allow the herd immunity to occur by allowing the, let's say, children to go to school and become infected, and then allow that infection to spread, and they are asymptomatic and they would become part of herd immunity. But if the reinfection is start going to happen, then what would happen with that herd immunity? Again, we are building a castle on 5 cases out of 39 whatever millions. I do not know the current number. So it is a rarity. It is not something that is mainstream. It is not something that is happening every second. So based on this, making too many decisions may not be the right thing. But it is interesting that there is a confirmed case of reinfection. So with this is the discussion for today. I have all of these links present in the description. Also, there is a link to go and have free trial on Drbeen. All COVID-19 videos would stay free even when the free trial is expired. And there is a link as well there for donation. If you like my work, if you want to support that work, please donate as well. That would be helpful. So with this, let's see if there are any questions. Otherwise, we will break for today. So Debbie says, yes, it can persist. Debbie, this is a question really for the long haulers as well, and we have to figure that out. That can it persist, or is it just the immune system that has become dysregulated and now virus is gone, but the immune system is just like a car that doesn't have a driver, but it is going downhill and just continuing to go. Yeah, so Machiavelli says virus can infect bacteria. That is correct. Viruses can infect bacteria as well. So Terry says, unless I misunderstand, infectious is infectious. If you don't have antibodies, you can get infected. How much does it take? The average particle is 125 nanometer. How many particles does it take to become infected? So Terry, in theory, even one particle, when it arrives in our body, will say we are infected. It depends upon our immune response as well, that how many copies of the virus are sufficient to cause more replication or more division, more virus count, and then spread. If our immune system cannot halt it, then even a small viral load can spread fast. On the other hand, if immune system is robust, for example, in children, then a high viral load doesn't do much as well. So France says that I'm thinking back to pumping up innate arm plus regime. We have discussed absolutely. The innate arm has to be really robust. And then I wish that when the vaccines are there and vaccines are good, just like we see now Eli Lilly stopped and the Johnson & Johnson is stopping, AstraZeneca had a problem. If there are good vaccines, that would help as well to produce antibodies. So I think there is a discussion going on about the aerosolized virus from fecal matter as well. And I have done a discussion that flushing the toilet would create aerosols. And a patient who has recovered from the virus can still continue to shed through the fecal route for 2 months afterwards or 50 days afterwards. So there's a question that I hear a lot. Doctor, do you recommend flu vaccine? I do recommend flu vaccine. But once again, you have to talk with your doctor to figure out what is your body's condition. Can you take them both or not? And what would happen if you have the vaccine, you're ill with that, and now you have the virus as well. But I recommend flu vaccine. Debbie says, Dr. Bean, tons of cases reported in our COVID support groups. Official reports trickling out, but it's happening much more than official reports. Debbie, that is interesting. I keep hearing this as well, but until we have the facts available for data that the RT-PCR was positive, then negative, then positive, it could be mistakes of, number one, long hauling, or number two, other common cold viruses, even human coronaviruses that can create symptoms similar to SARS-CoV-2. So, and maybe because I do not have all the facts, maybe this is happening more frequently. Randy, you're correct. There are going to be so many types of vaccines that we're bound to find something. Absolutely, that is correct. E-Doc says, thanks, Dr. Bean. See you guys later. So perfect. And I think this is it for today. Debbie, perfect. So thank you very much for joining. Please like, subscribe, and share. That is my request to you. And I would see you tomorrow. Bye-bye.